This recording will cover renal cell carcinoma and kidney trauma. Renal cell carcinoma, or adenocarcinoma, of the kidney is the most common type of kidney cancer and occurs as a result of impaired cellular regulation. Systemic effects of this cancer type include anemia, erythrocytosis, hypercalcemia, liver dysfunction with elevated liver enzymes, hormonal effects, increased SED rate, and hypertension. Anemia and erythrocytosis may seem confusing. However, most patients with this cancer have either anemia or erythrocytosis, not both at the same time. The cause of the anemia and the erythrocytosis is related to the kidney cell production of erythropoietin. At times, the tumor cells produce large amounts of erythropoietin, causing erythrocytosis. At other times, the tumor cells destroy the erythropoietin-producing kidney cells and anemia results. Parathyroid hormone produced by tumor cells can cause hypercalcemia. Other hormone changes include increased renin levels, causing hypertension, and increased HCG levels, which decrease libido and change secondary sex features. Complications include metastasis and urinary tract obstruction. The cancer usually spreads to the adrenal gland, which you know is on top of the kidneys, liver, lungs, long bones, and the other kidney. When the cancer surrounds a ureter, hydroureter and obstruction may result. The most common treatment for renal cell carcinoma is a nephrectomy. When the cancer is local or only in the kidney, a nephrectomy can provide a cure. For patients with metastasis, nephrectomy is followed by targeted chemotherapy combined with cytokine treatment. Patients with renal cell carcinoma are at risk for chronic kidney disease and cardiovascular complications. When obtaining a patient history, ask the patient about his or her age, known risk factors such as smoking or chemical exposures, weight loss, changes in urine color, abdominal or flank discomfort, and fever. Also ask about whether other family members have ever been diagnosed with cancer of the kidney, bladder, ureter, prostate gland, uterus, or ovary. Some patients with renal cell carcinoma have flank pain, obvious blood in the urine, and a kidney mass that can be palpated. Ask about the nature of flank or abdominal discomfort. Patients often describe the pain as dull and aching. Pain may be more intense if bleeding into the tumor or kidney occurs. Inspect the flank area, checking for asymmetry or an obvious bulge. An abdominal mass may be felt with gentle palpation. A renal bruit may be heard on auscultation. Bloody urine is a common late sign. Blood may be visible as bright red flecks or clots, or the urine may appear smoky or cola-colored. Without gross hematuria, microscopic examination may or may not reveal red blood cells. Inspect the skin for pallor, darkening of the nipples, and in men, breast enlargement or gynecomastia caused by changing hormone levels. Other findings may include muscle wasting, weakness, and weight loss. All tend to occur late in the disease. Diagnostic assessments can include a urinalysis, which may show red blood cells. Hematologic studies may show decreased hemoglobin and hematocrit. Everything else seems to be increasing with hyperglycemia, increased erythrocyte sedimentation rate, increased levels of adrenocorticotropic hormone, increased HCG, increased cortisol, increased renin, and increased parathyroid hormone. Elevated or increased serum creatinine and BUN levels indicate impaired kidney function. Kidney masses may be detected by CT scan or MRI. Ultrasound is also used to detect masses or for initial screening. Kidney biopsy may be considered to help target therapy. Interventions are used to control the cancer and prevent metastasis. Microwave ablation or cryoablation can slow tumor growth. Renal cell carcinoma is usually treated surgically by a nephrectomy or kidney removal. Renal cell tumors are highly vascular, and blood loss during surgery is a major concern. Before surgery, the arteries supplying the kidney may be occluded or embolized by the interventional radiologist to reduce bleeding during the nephrectomy. Pre-op, explain the probable site of incision and the presence of dressings, drains, and other equipment after surgery. Reassure the patient about pain relief. Care before surgery may include giving blood and fluid IVs to prevent shock. During surgery, the surgeon removes either part or all of the kidney and all visible tumor. The adrenal gland may be removed when the tumor is near this organ. With a radical nephrectomy, local and regional lymph nodes are also removed. Post-op priorities are focused on assessing kidney function to determine effectiveness of the remaining kidney, pain management, and preventing complications. Monitoring includes assessing for hemorrhage and adrenal insufficiency. Inspect the patient's abdomen for distension from bleeding. Check bed linens under the patient because blood may pool there. Hemorrhage or adrenal insufficiency causes hypotension, decreased urine output, and an altered level of consciousness. A decrease in blood pressure is an early sign of both hemorrhage and adrenal insufficiency. With hypotension, urine output also decreases immediately. Large water and sodium losses in the urine occur in patients with adrenal insufficiency, leading to impaired fluid and electrolyte balance. As a result, a large urine output is followed by hypotension and oliguria, less than 400 mL per 24 hours or less than 25 mL per hour. IV replacement of fluids and packed red blood cells may be needed. The second kidney is expected to provide adequate function, but this may take days or weeks. Assess urine output hourly for the first 24 hours after surgery. Urine output of 0.5 mL per kilogram per hour, or about 30 to 50 mL per hour, is acceptable. A low urine output of less than 25 to 30 mL per hour suggests decreased blood flow to the remaining kidney and potential for acute kidney injury. H&H values and white blood cell count may be measured every 6 to 12 hours for the first day or two after surgery. Monitor the patient's temp, pulse rate, and respiratory rate at least every 4 hours. Accurately measure and record fluid I&Os and weigh the patient daily. A drain placed near the site of incision removes residual fluid. Because of the discomfort of deep breathing, the patient is at increased risk for atelectasis. Fever, chills, thick sputum, or decreased breath sounds suggest pneumonia. Managing pain after surgery usually requires opioid analgesics given IV. Preventing complications focuses on infection and management of adrenal insufficiency. Antibiotics may be prescribed during and after surgery to prevent infection. Adrenal insufficiency is a possible complication of kidney and adrenal gland removal. Although only one adrenal gland may be affected, the remaining gland may not be able to secrete sufficient glucocorticoids immediately after surgery. Steroid replacements may be needed in some patients. Kidney trauma to one or both kidneys may occur with penetrating wounds or blunt injuries to the back, flank, or abdomen. Other causes include urologic procedures such as extracorporeal shockwave lithotripsy, kidney biopsy, or percutaneous renal procedures. Blunt trauma accounts for most kidney injuries. Obtain a history of the patient's usual health and the events involved in the trauma from the patient, a witness, or emergency personnel. Document the mechanism of injury to help determine the severity of the injury. Ureteral or renal pelvic injury often causes diffuse abdominal pain. Urine outside of the urinary tract may be visible. Ask the patient about pain in the flank or abdomen. Ask them to describe it. What makes it worse? What makes it better? Assess patients with kidney injuries carefully and thoroughly. Take the patient's BP, apical and peripheral pulses, respiratory rate, and temp. Inspect both flanks for bruising, asymmetry, or penetrating injuries. Also inspect the abdomen, chest, and lower back for bruising or wounds. Percuss the abdomen for distension and inspect the urethra for blood. Urinalysis shows hemoglobin or red blood cells from tissue damage or kidney blood vessel rupture. Diagnostic procedures include ultrasound and CT. If the patient is being taken to the operating room emergently, contrast IV material can be given, followed by a KUB to visualize the traumatic injury and any organ damage. Drug therapy is used for bleeding prevention or controlled. The need for clotting factors such as vitamin K or platelets is assessed, and they are given as needed. Fluid therapy restores circulating blood volume and ensures adequate kidney blood flow. When bleeding is extensive, packed red blood cell replacement restores hemoglobin and promotes oxygenation. Fresh frozen plasma or coagulation factors may help with uncontrolled bleeding. Plasma volume expanders, such as dextran or albumin, help restore plasma oncotic pressure and reduce the onset or severity of shock or fluid displacement to interstitial tissue. During fluid restoration, give fluids at the prescribed rate and monitor the patient for signs of shock. Take vitals as often as every 5 to 15 minutes. Measure and record urine output hourly. Output should be greater than 0.5 mL per kilogram per hour. If the urethral opening is bleeding, consult with the urologist or primary healthcare provider before attempting urinary catheterization to avoid making the injury worse. Most kidney injuries are managed without surgery. Many serious injuries can be treated with minimally invasive techniques such as angiographic embolization, which accesses the arteries of the kidneys through large blood vessels in the groin, similar to a cardiac cath. Surgery to explore the injured kidney occurs when the patient is in shock or may be losing a lot of blood from the kidney. The goal of surgical management is to repair the injured kidney and restore its elimination function. Teach the patient and family how to assess for infection and other complications following kidney trauma. The most common complications are urine leakage and delayed bleeding. Chart 67-7 has patient teaching for preventing kidney and genitourinary trauma. It includes wearing a seatbelt, practicing safe walking habits, using caution when riding bicycles or motorcycles, wearing appropriate protective clothing when participating in contact sports, and avoiding all contact sports and high-risk activities if you have only one kidney. Please pause the video to read the questions and think of your answers, and then resume the video to hear the correct answers. For number 1, the answer is acute pyelonephritis. For number 2, the answers are urinalysis, urine culture and sensitivity, blood cultures, C-reactive protein, and erythrocyte sedimentation rate. For this second case study slide, the correct answer is D as in dog. For this third case study slide, the correct answer is D as in dog. For question 1, the correct answer is B as in boy. For question 2, the correct answer is B as in boy. And for question 3, the correct answers are B as in boy and C.